This mini lecture is on erectile dysfunction, and you may also hear it called impotence. As we think about erectile dysfunction or impotence, it's the ability to achieve or sustain an erection that is suitable for sexual intercourse. So they may not be able to penetrate the vagina because the erection is not firm enough, or they have an erection, but it is not maintained for the length of time that they need it to be to have sexual activity and to give their partner fulfillment. Or they may just not be able to have any erection at all. And this is really seen sometimes in the diabetic patients. But when we think about classifications for erectile dysfunction, we can classify it as mild, moderate, or severe. When we classify it as mild, it's usually that they fail to achieve a satisfactory erection 2 out of the 10 times. But if all attempts at satisfactory erection fail, then they classify it as severe. Moderate would be somewhere in between that group, but it's really difficult to estimate the number of men with it because the definition is so broad, and some men may not even bring it up to you as a female, and have a tendency more to bring it up as a male, unless you do bring it up to them first when you're doing maybe their intake or something. Some of the risk factors that we see with this is vascular, neurological, hormonal, drug-induced, or psychogenic. And a lot of these pertain to some chronic medical problems. Someone with cardiovascular disease, a diabetic, somebody who's hypertensive, smoking, high cholesterol, or have had a radical prostatectomy have a tendency to have erectile problems. As we all know, anybody with severe spinal cord injury or brain injury would have erectile problems. Hormonal could be related to hypoprolactinemia, hyper or hypocorticolism, excuse me, hypogonadism, and also if they have Peyronie's disease or a cavernous fibrosis, then those issues will cause the erectile dysfunction. Sometimes medications, so we have to watch what medications we put patients on. The antihypertensive drugs, calcium channel blockers, have a tendency to cause problems in males when they're taking them. They have difficulty with erections. Also, in regards to the antidepressants, some of the SSRI inhibitors have a tendency to cause problems with erectile dysfunction. And also the psychogenic issues related. Let me go back a minute to the drug induced. A lot of people that are on pain medications and that see pain specialists for chronic pain have difficulties with erections, and obviously recreational drugs. But when we also look at the psychogenic portion of this, anxiety because they're concerned about their performance, and maybe they have a new partner and they're really stressed out about it, so they want to perform well, and that causes a problem. Sometimes when they are going through relationship problems at home, and I do ask them this when they come in with these problems, I ask them, are you having any difficulties at home? Are you and your wife getting along? And then sometimes some of this will start to come out. Also, stress in the work environment is a huge risk factor for erectile dysfunction. The physical exam, we should do a posterior blood pressure because a drop would be indicative of maybe some type of autonomic or adrenal insufficiency. Looking at their loss of secondary sex characteristics, also doing a genital exam on them. Do they have phimosis? Do they have Peyronie's disease? Do they have any type of inflammatory process? Are they circumcised? And then also, thinking about the occlusive diseases that we might see in the aortic or femoral arteries. So doing a really good cardiovascular exam on these patients. And then spinal exam, obviously, and neuro exam, testing for any anal sphincter contraction abnormalities. So how are we going to diagnose them? Well, initially, the lab tests that rule out causes of erectile dysfunction should be done. These tests would include your fasting blood sugars to rule out diabetes, any lipid profiles to rule out dyslipidemia or thyroid hormone issues, and testosterone levels. If the testosterone level is below 200, then you should go ahead and do a serum prolactin level. Lab tests for patients with established erectile dysfunction should also be a CBC as well as a chemistry panel and a PSA in men even as young as 40 if they have a family history of prostate cancer. So looking at all these levels helps to come up with some type of diagnosis for the patient. So now as we've looked at the lab work and have those labs back and determine if there what kind of issue is causing the problem, then we can determine on how we're going to manage the patient. So, you know, we have to think about a lot of other differentials here. We have to think about, any type of trauma or urethritis. We have to think about any malignant tumors. Is there urethral strictures? And if all of this stuff is negative, then we think about how we're going to go ahead and manage this patient. So non-pharmacological, we could do sex therapy and have the both either the spouse or the significant other involved in that for psychological support, or using a vacuum catheter. The vacuum catheters usually take just a couple minutes to start using. The patient would insert his penis into a cylinder and then uses the pump to create a partial vacuum, which actually causes the venous blood to enter the corpus cavernosa, and then that would help them get some rigidity. Once they get a sufficient erection with that, then they place a ring around the base of the penis to help maintain that erection. And this is non-invasive, so some patients do get really good results with this. It is costly, though, anywhere between $300 and $500. We can also look at the pharmacological treatment, looking at the PDE5 and medications. They are vasoactive therapy, so using Viagra, Cialis, the Levitras. These drugs were developed and have done a very good job in helping with erectile dysfunction in men. Viagra was the first of these drugs to be given to patients, and what these do is they actually increase blood flow to the penis for successful erection. The standard dose of Viagra is usually 50 milligrams at least 1 hour before sexual activity. And there are some contraindications, so you need to be aware of what those contraindications are also with these medications. Also, then you have your Cialis and your Levitra, which work pretty much the same way as the other ones do. They really do not affect the libido, and they do not initiate an erection without sexual stimulation. So if you just take a Viagra or you just take a Cialis or a Levitra or a Stendra, you can't just sit there and wait for it to work. You need to have your partner be doing some type of foreplay in order for this medication to work. There's also hormone therapy for men with documented testosterone deficiencies who do not have prostate cancer. That could be a treatment of choice. But if you're going to put these men on hormone therapy with testosterone, you need to check a PSA level before you put them on and make sure it is a normal PSA level, because testosterone therapy can feed prostate cancer. It is a hormone, just like the testosterone is a hormone that you're giving the patient. So it will exacerbate it, and you want to make sure that you're checking these PSA levels at least every 6 months, maybe even 3 to 4 on these patients. It just depends on what you're comfortable with. But they need to come back and get those tests done, or you don't give them their refills on their testosterone levels. There's also the intracavernosal injections or suppositories. So we call that the Caverject or the Muse, and those also can be used. Men do get good results with those. They're not cheap, though. They are expensive. And then reducing the dose of their current blood pressure medicine, switching them to a different agent. So switching them like to an ACE inhibitor or calcium channel blocker sometimes will work, although the beta blockers in themselves can cause erectile dysfunction. And some of the calcium channel blockers do. If you reduce the doses, they have a tendency to decrease their risk of getting that. So I do have many men on calcium channel blockers with low doses that don't have any problems with those medications. And then you can also switch them if they are on an SSRI to a tricyclic antidepressant, and that does help them quite a bit because it takes those SSRIs have a tendency to really cause some erectile problems with males.